Okay, when you're looking at a patient who may have a history of type 2 diabetes or is diabetic, you want to look for risk factors, family history, weight changes, vision changes, any recent infections, reoccurring yeast infections, and these don't just have to be in women; it can be in in different skin folds of both men and women. Remember, anywhere warm, dark, and moist can grow yeast, especially if it has a sweet medium. So if the its blood sugars are high, they have an increased risk of yeast infections. Um, or a history of wounds that will not heal or healed slowly. Those are all things that we would want to look for when doing the assessment of a patient, um, when we're concerned about looking at diabetes, especially type 2 diabetes. Assessment diagnostics. Not only are we going to do a fasting blood sugar on this patient, or perhaps we'll do just a random blood sugar on the patient, we're going to want to do a urine for ketones. They're going to look at their albumin in the urine, protein in the urine, and is there glucose in the urine. Also, other things we're going to look at is a hemoglobin A1C on this. So, what is a hemoglobin A1C? It is a lab value that reflects the average glucose over several months, about 3 to 4, and it has a strong predictive value for diabetes complications. Measures how much glucose permanently attaches to the hemoglobin molecule. So this level kind of doesn't allow the patient to fudge their numbers, so to speak. Um, and it gives a better understanding of what this patient's blood sugars have been throughout the last 3 to 4 months um, before the visit. With most type 2 diabetics, they want to see that hemoglobin A1C less than 7. Um, this may not happen. A lot of times these patients will have hemoglobin A1Cs in the 12 to 13 range. And so it's going to take it may take 6 months to get them down to a 7, or even longer than that. And then they may fluctuate between a 7 and an 8. Especially for our older adult patients with type 2 diabetes, the endocrinologist may determine that a 7 is no longer realistic and try to get that patient to an 8. But for testing purposes, the goal of a hemoglobin A1C in your type 2 diabetic is a hemoglobin A1C less than 7. Care of the patient with diabetes. Planning. What are our expected outcomes? The American Diabetes Association has proposed the following treatment outcomes. You want to be able to maintain that hemoglobin A1C less than 7. They want a pre-meal blood sugar to be between 70 and 130, and their postprandials to be less than 180. And that's usually taken 2 hours after the meal, because a postprandial blood sugar needs to be when the food that has been eaten has had time to digest and the sugar from that meal has entered our system. I hope that makes sense. So, again, the American Diabetes Association has proposed the following treatment outcomes. It is to maintain a hemoglobin A1C less than 7. They want pre-meal blood sugars between 70 to 130. Postprandials, which is usually about 2 hours after meals, less than 180. Care of the diabetic patient, planning expecting outcomes. Whether it's a child with a type 1 diagnosis or an adult with a type 2 diagnosis, a new diagnosis of diabetes may be overwhelming. For our purposes for this class, we're going to concentrate again on the patient with type 2 diabetes. And this diagnosis may be overwhelming. It may cause depression. It may, when they first see what all they're going to have to do in changing their lifestyle, it just may be very overwhelming. We need to look at nutritional interventions that are purposeful and doable for this patient. You're not going to tell a truck driver that he needs to make 3 heart healthy meals a day and 2 snacks. You're going to have to work within their, you know, lifestyle in order for them to realistically make these nutrition changes. Need to impress upon them the importance of blood glucose monitoring. They need to look at a plan for exercise. And, a lot of times these people haven't exercised in 20 years. You can't expect them, they're not going to run a marathon next month. They need to start out slow and steady and increase their exercise over a period of time. They also need to understand the importance of maintaining their medication regimen. Care of the diabetic patient medications. Now, when we're talking about anti-diabetic medications, we're talking about our type 2 diabetics. And what we need to look at is also the choice of medication may be based on, let's put code, that's cost, patient's ability to manage a multi-drug regimen and response to the medications. It may be that the patient's insurance, you really need to be able to look at what the patient's insurance is going to be able to cover, and what's the patient's ability to manage multiple drug dosing, or if they're taking different types of anti-diabetic medications that have different actions. You need to make sure that you're teaching them about those medications so they understand the importance of taking multiple types of anti-diabetic medications. You also need to make sure that they can afford them. You don't want to put them on the latest and greatest for them to find out that it's $500 a month and they only make, $1,500. They're not going to be able to afford it. Or even if they, make more than that, $500 for one medication is not going to be sustainable for extended periods of time. And with our patients with type 2 diabetes, we need to not only get their blood sugars under control, but it needs to be something that they can maintain for their life. So we're going to want to make sure that with the choice of medication that we look not only at cost, but also the patient's ability to manage a multi-dose regimen and their response to the medication. When we're looking at the elderly, we need to look at reduced vision, how mobile, how is their dexterity, and a lot of times these patients have decreased memory loss. You don't want to put them on a complicated regimen, or you don't want to put them on some of the newfangled anti-diabetic medications that are injections if they're unable to see the pen in order to give themselves the injection, or they're unable to inject themselves with medication. You really need to look at your patient and help the providers, because sometimes I think the providers say, well, this is the best medication to get their blood sugar under control, but they're not looking at their patient. And that's where the nurse comes into play and goes, have you met Mr. So-and-so? Do you really think he can do that? Or before the patient, if the patient's in the hospital, before they leave the hospital, say, hey, you call your insurance company and make sure that this medication is covered by your insurance, because it's pretty expensive. A lot of times the diabetic educator or the diabetic navigator will help the patients with that, especially with a new diagnosis. But these are important things to look at when looking at anti-diabetic medications for our patients with type 2 diabetes. Again, when we're looking at medications for our diabetic patient, now I told you we're going to talk a lot about type 1, but there are some things that we need to be impressed upon, that if a patient has, if a patient has type 1 diabetes, they always have to be on a basal insulin. Type 1 diabetics must have a basal insulin. They may have an insulin pump. They may take a long-acting insulin either at night and then take shorter-acting insulins during the day. The timed activity of pharmaceutical insulin is on chart 64A. Now, our type 2 diabetics, a lot of times they're on anti-diabetic medications. They're a lot of times on oral agents or subcutaneous injections. See chart 64-2. Most of the time, they're on a combination of drugs with different mechanisms of action, and sometimes this does include insulin if the patient's pancreas has become tuckered out and isn't making enough insulin to support the patient. But the main thing I want you to know with type 1 diabetes is that they are always on a basal insulin. And remember that our type 2 diabetic is a lot of times on anti-diabetic medications. They can be on different oral agents and subcutaneous injections because sometimes it requires a combination of drugs with different mechanisms in order to control their blood sugar. I'm going to stop this recording here, and we will pick back up with insulin. Yay, fun. We'll be on part 4 here shortly.